Hello everybody! We are going to do chapter 20 a little different than what we've been doing. Chapter 20 really gets us into some of the tools that we need to provide diagnostic Doppler images. So I want to go through some of the concepts that are discussed in chapter 20 live on a machine so you can see what it looks like when we increase the PRF, when we change the angle of incidence, when we decrease the well filter, when we change all these tools to really help us get an idea of how these physical properties work with Doppler. Now, a couple things I want you to keep in mind while we are talking about this. I'm going to be showing you examples off of my carotid artery. It'll be probably the best spot for me to hold a transducer, talk about things, and to show you all the things that we need to talk about. If you're a general student, this is going to be a little bit more familiar territory to you. You haven't learned carotid anatomy yet. And so what I want you to keep at this point as a general sonographer, and what I want the echo students to remember, is that the physics boards are made for both echo and general sonographers. So it doesn't matter that you don't know the anatomy. It doesn't matter that you don't know which way the blood should be going. What matters is that you're paying attention to the parameters that you are seeing on the screen so you can determine which way the blood is flowing. That's all you need to do. The next thing that I want you to pay attention to is what happens when I change certain things. Otherwise, everything that I'll be showing you today is covered on your SPI, your physics boards, so it will be important that you understand the concepts. The other thing is I am working on a little bit older machine, so I don't have some of the tools that are on the newer machines, but I feel like this will be a very good representation of what basic machines should be able to do nowadays. And unfortunately, the video is not super duper, but that's okay. I think you guys will get the idea from what you are seeing. I'll do my best to describe what I'm changing, numbers, what they read out on the screen, so you can kind of follow along with everything that I'm doing. Alright, so let's go ahead and get started, and we're going to start with normal incidence. Now, if you remember way back to chapter 6, we talked about normal incidence being that sound is coming out of the transducer and striking our interfaces at 90 degrees. Now, I am using a linear sequential transducer, so that means that my transducer face is up here, sound is coming out directly from those crystals down through my image. So this black bar that's kind of going through the middle here, this is my carotid artery. And if I can get it straight across the screen here, we will be coming at that artery with a 90-degree angle or normal incidence. We are pretty close to 90 degrees. We've got nice crisp borders. So 90 degrees is awesome for our black and white pictures. It gives us really nice reflection back to the transducer. I'm going to angle this artery a little bit. And I'm going to start to lose some of that information. Look down here. Look where it's super angled. My walls are super fuzzy. I'm just not getting that same information that I am up where it's 90 degrees. So normal incidence, again, is 90 degrees. Now we're talking about this in the realm of Doppler. And I'm going to turn color Doppler on. And if you recall, when we are at 90 degrees, theta 90, cosine of 90 is 0. And it negates the whole Doppler equation. It makes it so the machine cannot figure out which direction to or from the blood is moving. So let's get this 90 degrees again. So we are getting a little bit of color in there, probably because that part is ever so slightly angled. But I'm going to show you when I angle this vessel, watch what happens. It starts to fill wall to wall. So we have to have an angle when we are Dopplering. I'm going to go back to 90. And you can see me talking. This is all kind of artifact because this is false information that's being displayed. So here we are again at 90. We are getting information, but I can tell you right now, this is all wrong. My carotid artery is not flowing in a bunch of different directions. I angle the vessel, and I start to get really nice color fill wall to wall. Let's take a look at what we're seeing here. We're seeing blue is towards, so the machine is detecting that this blood is moving from the right of the screen to the left. It's moving up towards the transducer. Now typically we do like to display arteries as red, so I'm going to go ahead and invert that. With one push of a button, I can change, is it blue or is it red? But I'm changing my color map. So I'm getting awesome color fill in here because I'm angling my vessel. Back to horizontal, 90 degree, normal incidence, barely any color in there, angled. Now the other awesome thing that we have with current technology is that we can angle this box. This yellow box that is around the vessel is called the color box. And when we angle the color box, we tell the scan lines that are creating the information in the color box to be steered either to the right or steered to the left. So again, to the right or to the left. And then we can have a center steer as well. The other thing we can do with this color box is change the size of it and move it around. We can change the size. When we make it smaller, we are using less Doppler packets. We're using shorter ensembles. So we're only getting a little bit of color information, but the frame rate is going to be much better. So the goal is to set your box appropriately so you're covering the area that you want to cover with getting the right information. And again, remember, we can move it around as we need. So I'm going to set this up as it should be. When we are steering our color box, we want to make sure that we are steering it with the blood flow. So right now I have the vessel kind of angled down this way towards the right. So I also want my box steered towards the right. What that's going to do is give me the best angle on that blood flow so we can be really close to that 60, 45, 0. So look what we're getting now. Beautiful wall-to-wall fill. Now I want to show you something else. When I angle to the left, if I angle incorrectly, I am now creating a 90-degree angle incidence. These lines are angled this way, but my vessel is angled this way. And so even though everything is angled, they are still at a 90-degree incidence or normal incidence. So we are not getting the color information that we need. Again, you want to make your lines at an angle to the blood flow. More angle is better. So here I'm a little bit closer to that 90 degree. I can heel toe and give my vessel even more angle. A little bit more 90. I'm still getting color flow, but I get really awesome color flow when I angle it more. So some key ideas with normal incidence. We cannot detect Doppler changes when we are incidentating at 90 degrees to the blood flow. You must have some sort of angle to the blood flow. So you have two options. Come in at 0 degrees, use the correct window that gives you that 0 degrees, or push your probe, heel toe it, so you introduce an angle of the vessel that you're looking at to get an angle with the blood flow, or steer your color box so your color box is angled with the blood flow. Best practice is to not only heel toe, but to also steer your color box. Remember that if you are not angled and are using that 90-degree angle of incidence, you might show no color flow, which might lead to an improper diagnosis for the patient. Moving on, we're going to talk about color gain. Now, color gain is the power, basically, or the strength of the echoes that are returning from the blood flow, the part that is being instillated for color Doppler. And just like B mode gain, we can increase the color gain. It's going to amplify all of the echoes that are coming back, but it's going to make it stronger. It's going to display more on the machine. Conversely, we can turn down the color gain and make it so it looks like there isn't any flow. So let's take a look at this. Here we are on the vessel. We have nice color gain, a little bit of angle, we're wall-to-wall fill. We actually are coming out a little bit of the vessel with that color. And a lot of it's because I'm talking. I'm going to stop talking for a second here. And you can see we are filling wall-to-wall. So this is actually pretty appropriate color gain. I'm going to increase the color gain. And look what happens. All of this flashy color, complete filled in box, there's nothing diagnostic going on here. This is way too much color gain. Now we can back off on this a little bit. And what we'll start to see is the vessel will still fill. I'm still getting information, but it's still not diagnostic. So our goal is to turn our color gain down so we are showing blood flow within the vessel appropriately. So here we are again, still bleeding over a little bit. I'm going to keep bringing it down just so I get it to the vessel wall. That looks nice there. We're getting wall-to-wall fill. Now, conversely, we can bring that color gain way low. And look, it looks like I hardly have any fill in there. Again, as a sonographer, you need to pay attention to your tools. You want to make sure that you're using the right tools, that they're set appropriately, so you're providing the correct information for the radiologist or the cardiologist to review. I'm going to bring that color gain back up again. We typically want, again, wall-to-wall fill, or we want to be able to recognize any jets that we're seeing off of valves as that blood moves. The next concept that we're going to cover is spectral gain. And we're going to cover a few of the spectral pieces before we move into that. So I'm going to pull up my pulse wave. The pulse wave is usually how we refer to the Doppler that we are used to that creates that spectral tracing underneath. So a couple of things that I want to point out. We have this one single line coming down. That is the one scan line that is being used to collect the Doppler information from within the cell. We have the two parallel lines that are seen kind of in the middle of that pulse line. That is our volume, or our spectral gate. That gate, we are capable of moving that around. So we can move that around. We can select where we want to get our Doppler information from. Remember, that is range resolution, the fact that we can select where we want it from. And then you'll see another line in the middle, and that is called our angle correct. Now, when we are using our angle correct, we want to make sure that it is placed parallel to the flow of the blood that we are looking at. That way, the machine can then calculate what the angle of inclination is between the angle correct, which is signifying the direction of blood flow, to the scan line that we are getting. I'm going to set this back up again. We always use color to help us identify where the blood is flowing, where the fastest blood flow is. Typically it's in the center. So I'm just going to freeze there for a second. You can hear the sound of the blood flowing. What we are hearing is actually the Doppler shift. Remember, it's between 20 hertz and 20,000 hertz, that's within our audible range. So what we are actually hearing is the Doppler shift. So that's what we can hear when we're listening with Doppler. Recall we have our baseline. This yellow line here is the baseline. We have the waveform, the spectral tracing are all these white little dashes. Recall that those are representing the echoes that are returning from within the gate. This caliper up here is measuring the peak systolic flow, or the maximum velocity that this waveform is displaying. This caliper down here is displaying the end diastolic flow, which is the last part of the cardiac cycle before it starts again. What is the velocity of the blood at that moment in time? We can see our spectral windows here. These are these black kind of triangles underneath the peaks. Those are nice and clear when we are using a smaller, appropriately placed gate. Along the side here, we have our velocities listed. We can see that the unit is in centimeters per second. We have a positive shift above the baseline, up to 150 centimeters per second is able to be displayed. And then we have negative shift below, down to probably, my guess would be about 40 centimeters in the opposite direction. Along the side here, these numbers are probably a little blurry, but we can see all of the information that we've been using. We have our B mode information, we have our color flow information, and then we have our pulse wave Doppler information as well. The big important one right here is this AC 60. If you recall, we talked about having to have our angle correct at 60 degrees or less. This is where you're going to see that information. What is our angle correct at? Kind of cover some of those key things that we're looking at while we have pulse wave Doppler active. So let's go ahead and go live again here. Right now we have spectral, color, and B modes. We are technically triplexing right now. Sometimes people do just refer to this as duplex examining. Technically is triplex when we have all three modes going. So here is my angle steer. I want to just show you how I can adjust this, and you see how it's changing the angle that my pulsed beam is going at. We want to make sure that that is also angled, because any angle we can get is better than none. And then I want to show you when I change the angle correct, watch this number on the side here, this AC number, we can change, and as that changes, the angle correct line also changes. So we want to make sure that we are always placing that so it is parallel with the blood flow. So an angle correct of 54 is actually very appropriate for the angle that I have on this vessel here. I do just want to point out that standard practice, we do usually keep it at 60, just because that is a very reproducible number when we are imaging in the body. We can take that all the way down to 0. Watch how the line becomes almost 1 with the pulse line. That is assuming an angle of 0. If I were to use the angle of 0 right now, that would give me highly inaccurate information because I am not parallel with the actual blood flow. The angle correct is used to tell the machine this is how the blood is flowing. I would be incorrect if I kept it at 0 right now. So I'm going to go back to our 60 degrees. You can see as I get above 60, the machine warns me. I don't like that. I've turned red numbers. So it's going to tell you we don't like above 60. So we'll go back to 60. Let's get a nice view on our vessel here, and we'll start the pulse wave. Right. So again, we have a nice clear black anechoic background to our spectral tracing here, so that's appropriate. We have nice clear windows, that's appropriate. We have actually a very bright white line here that we would be able to measure if we wanted to. So this is all actually set up very nicely. This part here got a little bit later because I started falling off the vessel a little bit. But I want to show you how spectral gain changes the appearance. So I'm going to get a pulse wave started again. And what I'm first going to do is increase the spectral gain to show you what happens. And the other thing I actually want to show you before we move on, this is a nicely set up vessel. So I'm going to say here my peak velocity is at about 61 centimeters per second. So remember that 61. So now I've increased the spectral gain, and what you saw happen was that we started to get kind of all these snow, dirty background, and that's all noise back there. And so this noise is not helpful to the picture. The other thing I want to point out that happened is that we started to fill in our spectral tracing. It also increased the amplitude of the return echoes that were being displayed as well. That line got super bright, kind of fuzzy. It's not nearly as crisp as it was. The other thing I want to show you, I'm going to measure my peak systolic here. Remember the last one was 61. This one is coming in at, so this one is coming in at about 73, 74 centimeters per second. So when we increase our spectral gain, we are also increasing the velocities that we're going to be recording. And that's just because they're more visible. If we were to measure to that peak again, we'll get a higher velocity. This is falsely elevated. So we want to make sure that we have our spectral gain set so we have a nice anechoic background to a nice crisp spectral tracing. Now let's take a look at what happens when we decrease the tracing. Or the gain of the tracing. So here's my vessel. I'm going to angle it so I get even better color flow. I'm going to get that angle correct, just parallel in there. I'll get it started here. So in this example, I have changed the spectral gain to be very low, to the point where we can even barely see the peaks, see the waveform. Let's go ahead and measure this one to see what this looks like. So we got 74 with the spectral gain too high. We got 61 when it was set appropriately. Now we're only getting 47. I can tell you that the difference between 47 and 71 might be the difference between a patient getting surgery. It might be the difference between the patient getting followed up in 6 months versus never having to come back. So again, very important as a sonographer that you are setting your Doppler settings appropriately so we are getting good diagnostic information to the radiologist or to the cardiologist. Now the radiologist or cardiologist might look at this and might think, that's what they got. I trust my sonographer. This is what I'm going to read. They're not going to know that you had your settings all sorts of messed up. So it's very important that you understand the Doppler tools that you have. Now the next concept that we're going to talk about that's in the book is the idea of aliasing. Now I touched on this very briefly when we were looking at how to determine how blood is flowing in a vessel. And I talked about how the different colors that we're seeing, what does that mean? So let's kind of just recover that again. When you are imaging, typically you want just a nice solid color. This probably won't look as good in the video of a recording, but it is a very nice red. We're getting maybe a little bit of yellow in there, just showing that we are moving towards the top of our velocity scale, our color map on the side. What I'm going to do is I am going to decrease the PRF, or I'm going to decrease the scale, which lowers our Nyquist limit. And if you recall, when we lower the Nyquist limit, we introduce aliasing. So at 31 centimeters per second, we had some nice red with maybe just a touch of yellow in it. I'm lowering the scale down to 15. So what lowering the scale has done, or lowering the PRF, has made the machine a little bit more sensitive. So now we're actually seeing some color spilling out off the side. So I'm going to actually turn my color gain down to accommodate for that. But the whole point of this is to look at the color fill that we're getting in the vessel. So let's get this centered here. I apologize, my arm has been in the way for half these pictures. Let's reduce the scale a little bit more. So we really want this to stick out. Okay. So now what we are seeing is some blue showing up in our picture. Again, I apologize if you can't see this super well, but we do have some blue popping into our picture. So we have a dark red. That dark red is near the baseline. Then we have some brighter reds, some yellows, and then we get all the way around to some blues. So what we are looking at here is aliasing. And we know that it's aliasing because we are moving from a yellow into a blue. The color is wrapping around and showing a new color. Let's go live. I want to see if I can get this a little bit better for you guys. Actually, my internal jugular vein is doing it really well back there. So here we go. Perfect. There we go. All right, we're doing a close-up. So here is aliasing. What you can see is that the colors have gone from dark red to an orange to a yellow to a kind of a white, back to a light blue to a dark blue. That is aliasing. When we wrap around the color scale, when we go from what has been supposed to be, oh my goodness, this is a mess. Sorry guys. What was supposed to be towards has now been displayed as away. And so it really changes the information that's getting displayed. So aliasing is that wrapping around. Now I want to compare that to color flow direction change. So let's go ahead and go live again. And find a spot here. Alright, so I have found a spot where I'm actually seeing some true flow reversal. When we are up in the carotid bulb is typically where we see this. So the difference, remember, aliasing moved through the colors wrapped around to the other side. The difference for a true flow reversal is when we see that black line in between. So look, we've got red, black line, and then blue. That means that that is a true flow reversal. We're not aliasing there. We are actually changing the direction that the blood is moving compared to the transducer. Now, as far as some thoughts about aliasing, I do just want to throw it out there that aliasing can actually signal to us where those really fast jets of blood are. They tell us that the speed of the blood has exceeded the Nyquist limit. That's why we're getting that aliasing in the first place. So that can actually kind of draw our eye to the area that we want to measure. So it's not uncommon for a sonographer to set their settings with a little bit of aliasing to maybe pull that fast moving blood to their eye, but then they might adjust some settings to get that nice solid color later. So I want to just kind of show you how that works. Let's change our angle here and get set up again on the vessel. Alright, so we're angled on that vessel. So here we have a nice solid red with a little bit of yellow. I'm going to again decrease the PRF, or decrease the scale, so I can kind of see where that faster blood is. I would expect to start to see it right in the middle of the vessel, and that's exactly where it's popping up. I don't have disease in my carotid arteries. I don't have any stenosis. So we're seeing the fastest flow being displayed in the middle of the vessel. Now when we use that pulse wave, we can pull up our pulse wave, and then we can choose that fast flowing area based on where the aliasing is. Compare that to going to the side here. It's just not as pretty or as high of a velocity. So we can use that aliasing to our advantage to recognize very high flow jets, either through a stenosis or through a valve. Now the next concept that we will talk about is the idea of the wall filter. Now the wall filter is responsible for kind of getting rid of some of those low level echoes that are returning that are very close to baseline. So remember, our baseline is this yellow line in the middle. And let's start with spectral since we have it up. So we'll start with the spectral baseline. I'm going to get a waveform started, and then I'm going to turn up the wall filter. When you turn up the wall filter, what you're telling the machine to do is to reject or get rid of, again, those low level echoes that sit near the baseline. So what I want to point out is what it did. So here we can see our waveform, and look what happened here. We almost have this like floating waveform, and that's because the wall filter has been turned up to get rid of these echoes that hang out in this area. Let's start the waveform again and look at what happens when we decrease the wall filter. So notice here, this is where we are decreasing. It has started to fill in that spectral window. So again, we want to use our wall filter appropriately. We want to get rid of some of those low-level echoes so we show a nice clean waveform. But we don't want to get rid of so much that we start to alter the waveform. Another example that I want to show you with using incorrect wall filter settings is taking a look at what it looks like when we have blood flow above and below the baseline. All the examples that we've been using so far have been above the baseline, always flowing forward. Those are considered monophasic waves. Let's see, just had to get a little bit more gel here. Let's go ahead and look at a vessel that typically is triphasic. So I'm going to look at this vessel here. Look at how my color is not filling in very well. It's because I am kind of at an odd angle to it. So I need to change my color box so I'm angled the correct way. That'll help me to get more blood flow in there. Then we can bring up my pulse wave. Right now I'm aliasing. It's because I'm actually going to need to invert this. So here's a triphasic waveform. What we are seeing here is the peak systolic, a little bit of relaxation, and then some forward flow again. I'm actually in my subclavian, left subclavian artery at the moment. So what I want to show you is what happens. What do you think is going to happen when we increase our wall filter? Remember, we were kind of floating above. This is all blood flow. This is all true blood flow that we're showing here. Let's take a look what happens when that wall filter gets increased. There it is. That's the blood flow that the machine has been told to create. So now we have really messed up what that subclavian looks like. It looks like there's disease possibly happening. We're not getting the right information. So again, it proves just how important it's going to be that your settings, you check them for every picture, you adjust them, you make them appropriate for what we are seeing. Now, as you keep studying ultrasound, you will know what's normal. That's why it's your responsibility to know what's normal very, very well, so when things are abnormal, you can recognize it. You need to be able to recognize how to set your machine up to capture normal blood flow. Let's take a look then at what wall filter does for color Doppler. So here I'm going to increase the wall filter. And look, we're kind of missing some information along the actual wall, and that's because that's where our slowest blood flow is. So the machine is trying to get rid of that information. Watch as I decrease the wall filter again. We start to fill in wall to wall again. So the wall filter can help us to get rid of some of those low-level echoes that might just be kind of cluttering the area, and we just want to clean it up, be it with color or with our pulse wave Doppler. Now, the last concept that I want to talk about is the idea of aliasing. I know we already covered this in the Doppler lecture, but I want to show you it a little bit more, and that is because on your boards, when you're scanning at clinicals, when you're scanning in lab, you're going to see aliasing, and you really do need to know how to fix it. So I just want to review that those 5 concepts that we talked about. So let's get our color on. And we actually have really nice blood flow right now. I'm going to reduce some stuff here. I'm not going to tell you what it is right now because we've got to fix it in a second here. But I'm going to get some aliasing going on our screen. Alright, so there is a waveform that has aliasing. We can see our baseline here. We see the tops getting cut off. They're wrapping back around. And the actual peak of this vessel is, or this waveform is actually right about here. So it's wrapping around, we're getting that aliasing. So one of the first things that we can try changing is the baseline. Is our baseline set in an appropriate spot? So let's go live again. And we'll get another waveform going. So I'm going to try changing my baseline. Well, that's not fixing anything. I'm going to bring it all the way low. That didn't fix anything. So fixing the baseline in this case was not the right answer. Let's take a look at a spot where it could be the right answer. Say we're here, this is our aliasing. All we would need to do is lower that baseline, and we are no longer aliasing. So changing how your baseline is situated can correct for aliasing. That's probably one of the easiest things to fix, one of the most noticeable things to fix. Now, one of the other things we can try doing is changing our PRF. So here we are again, aliasing. My scale on the side here is set to 20 centimeters per second. That is the velocities that the machine can record before it will alias. Now when we change our PRF, we are changing the scale. So if you increase your PRF, you're increasing your scale. As I'm increasing my PRF, you can see that the waveform gets smaller, but I'm getting higher numbers on the side here. I'm going to max the system out here. Looks like about 200. So we have eliminated the aliasing because we have increased our PRF, which increases the Nyquist limit, which then allows the whole waveform to be displayed on our spectral tracing. So move your baseline, increase your PRF. Now let's say we had increased our PRF all the way, but we were still getting aliasing. It's a thing that happens. The next thing that we can try to do is change frequencies. And I think I have the opportunity to change frequencies on here. You can try changing probes. You can try changing frequency settings on your machine. Alright, so here I'm at a 6.7 megahertz. I'm aliasing. I'm going to lower my frequency down to 5 megahertz. And I've eliminated some of that aliasing. So lowering your frequency, be it through changing probes or changing parameters on your machine, will help you to eliminate aliasing. Another way that we can eliminate aliasing is through changing the depth. So I'm going to try to kind of show you what we're talking about with changing depth a little bit. Right. So I'm going to show you on the first one that I'm going to show you is looking at the vessel with its super heeled toes. The area that I'm interested in is deeper into my picture. So my gate is much deeper into the image as well. We're getting a little bit of aliasing. We can see that the tops of the peaks are getting cut off. Now I'm going to change how it's angled so that brings that area that I was interested in closer to where we were. And that's the best example, but we can see now that we are no longer as close to the peak. So when my gate had to be lower or deeper into my image, that was causing the PRF to be lower. As I moved it up higher, we can see then that the PRF was able to be raised, the Nyquist limit was able to be raised, and therefore we no longer have that aliasing. Whatever. Okay, and then of course the last choice that we have to reduce aliasing is to switch to a continuous wave probe, which I don't have for this machine. So again, the ways that we can reduce or eliminate aliasing is to change the depth, change the PRF, change the baseline, change the frequency, or lastly, to switch to continuous wave Doppler. Now the last concept that I want to talk to you about, we talked again a little bit about it during our Doppler, is changing the PRF or changing the scale. And when we change the PRF, when we are in color mode, let's get back to color here. Take our pulse wave off. So remember that color is showing us the average of the speeds of velocities that are being displayed. So we can see on our color map, I don't know, you can see the 15 there, 15 positive towards the transducer. We have a 15 negative away from the transducer. And when I change my PRF, what I'm changing is the Nyquist limit, or what that is able to display. And so it's the same idea with aliasing and with color. We can change what that Nyquist limit is with color. So let's go ahead and get a nice vessel here. We're seeing flashes of blue. We're getting a little bit of aliasing. If I increase my PRF, these numbers are going to go higher. So a little less aliasing. I've got it increased now to 37. Really no aliasing. It's very kind of slow flow because now those mean velocities are closer to the baseline because I've raised my PRF. Now I want to show you if I just max out the PRF on this system. So we're at 67. And look at what my blood flow has done. It seems really splotchy. There's absolutely no aliasing. But that's because my PRF is too high. My machine has become less sensitive to the slower velocities. So again, let's lower the PRF. We can see again that we have a nice wall-to-wall fill. Watch what happens when I lower the PRF to become too sensitive to flow. We start to get aliasing. And bring it all the way down. And look, we're just getting color all over the place. The machine is just too sensitive now to even fake flow, to a flow that's not really there. So again, PRF should be set to the appropriate number. That gives us that wall-to-wall fill. Maybe a little bit of aliasing, not too much. And nothing leaving the vessel walls. Same is true then for PRF. We saw as I increased the PRF scale, we saw that the waveform got smaller. We don't want our waveform so small that we can't see what it is, but we also don't want it so big to the point where it's aliasing. So increasing your PRF increases your scale that's displayed on the machine. When you increase the PRF with color, you're becoming less sensitive to the slower flow. When you increase the scale on spectral Doppler, you are decreasing the size of the waveform because you are decreasing where those Doppler velocities are being mapped out to. And that is kind of it for chapter 20, everybody. So I cannot encourage you enough to get out, get on a machine, practice some of these physics concepts. They will be more, they'll make more sense the more that you use them. They will become almost ingrained in your muscles. When you see that you're aliasing, you'll just know exactly, oh, I need to change my PRF. Oh, I need to change to this. I need to look at my baseline. The more you see that artifact, the more you see the wrong imaging technique being used, the quicker you are going to be able to recognize how to change it.